Hi everyone, Felix here, Advanced Clinical Practitioner with Eden Clinic. Now, a topic that I often get asked about is diet. So why do we get asked this? Well, it's commonly seen that those patients with testosterone deficiency will notice changes in their body habitus that they feel are not relative to their level of diet or exercise. And this can be the case. We often hear of guys suddenly developing central adiposity, otherwise known as the dreaded middle-age spread, despite no changes to diet and activity, and this can be just one of the many signs of hormone deficiency in men. So why does this happen? Well, there are multiple reasons why this can occur, and these range from actual derangement in physiological parameters such as low testosterone or thyroid issues, to simply just reaching a point in life where we become more financially secure and enjoy better quality food and drink, and generally are more tired, so we're less active than our younger years. And this time point for most is between 30 and 40 years of age, not to mention adding in having a family in between that time for some. So what about physiological reasons for weight gain then? Well, to look at this, we need to get a little bit, you've guessed it, get a little bit geeky. Let's start by looking at the accrual of adipose or fat tissue. Essentially, everybody has an individual basal metabolic rate. Now, this is the amount of energy an individual requires to just exist. And by that, I mean no movement, just the preservation of our physiological processes to maintain life. This is not to be confused with our maintenance calories. This is the amount of calories required per day to keep our body weight static. So, on that note, what is a calorie? Well, simply put, this is just a metric for a measurement of energy. Your maintenance calories are the required calories or energy needed to put into your body to maintain your body weight. So how do we lose weight then? Well, is that the right question? Not in my opinion. I think it's more nuanced than that. What we need to be thinking about is losing fat mass rather than weight, as we want to keep lean muscle tissue, as this is a healthy tissue type. Remember, the maintenance of muscle on our skeleton requires energy. Therefore, the more we can skew our body composition toward lean muscle mass, the easier it is to have less fat tissue on our frame. So what is a healthy amount of fat for a male in terms of percentage then? Well, anything between 12 and 15% is considered healthy and most importantly sustainable. Trying to sustain less than 12% body fat all the time is difficult and can lead to us not feeling good mentally and will certainly cause fatigue issues. We need to be cautious that we ensure we have a healthy relationship with food as well. So how do we achieve this holy grail of muscle to fat ratio then? Well, you may have heard this before, but it's because it's actually true, and it is simply just energy in versus energy out consistently over time. Now, the key there is consistency. As we lose fat mass, we need to increase either our energy out through calorie burn via exercise or reduce our calories consumed. Now, there is a critical mass point at which we should not drop calories consumed, as this essentially can cause our bodies to panic a little and start to lay down fat in reserve, as it feels like we are entering a period of food scarcity, and some refer to this as starvation mode, and this is usually up for debate in terms of the literature. The term that you're not eating enough to lose weight does have some truth, but we'll touch on that in another video maybe. So what is the best diet model? Well, put simply, the best diet model is the one that you'll consistently stick to over time. And I know that's not a very satisfying answer, and it's quite frustrating, but it's because it's true. So what does the evidence say then? Well, a comprehensive meta-analysis by G et al. In 2020 of the 14 most popular diet models used by adults for weight loss determined that, guess what? The most effective models were the ones that users adhered to over time. However, in addition to this, there were some interesting findings. They concluded that both low carbohydrate and low fat diets resulted in similar weight loss over 6 months, with low carbohydrate diets improving insulin sensitivity and both low fat and low carbohydrate diets resulting in similar reductions in systolic and diastolic blood pressure. However, low fat diets tended to show more favourable effect on a reduction in LDL cholesterol levels over low carbohydrate diets. So what about low carbohydrate, high protein and high fat diet models? Well, the most popular of this diet model is obviously well known as the Atkins diet, and this has been shown to negatively impact on cholesterol profiles and increase blood pressure. However, it has also shown efficacy in rapid weight loss. Interestingly, this diet model has been studied longitudinally in the Chinese population and has been shown to increase the risk of type 2 diabetes in that specific population. It's hypothesized, however, that this is due to the increased amount of protein and fat-based calories taking precedence over fruit and vegetables in the macro and micronutrient breakdown, and it's noteworthy that this effect was only seen in the group randomized to eating in a caloric surplus, and that ensuring a balanced approach is taken to what is included in the macronutrient breakdown, that the risk can be mitigated for through substituting some of the fats and proteins for fruits and vegetables. So, on to the part that you're probably all waiting for and the whole reason why you've tuned into this video. How then can TRT help with that unexplained weight gain seen in those who are testosterone deficient? To understand this, we need to do a little revision of sort of A-level biology. Yeah, more geeky talking coming. The breakdown of fat, or lipolysis to give it its medical label, is the metabolic pathway through which lipid triglycerides are hydrolyzed into a glycerol and 3 fatty acids. It's used to mobilize stored energy during fasting or exercise and usually occurs in fat adipocytes. Lipolysis is induced by several hormones including glucagon, adrenaline, noradrenaline, and testosterone and dehydroepiandrosterone, or DHEA. Now, when we think about lipid mobilization, this is where we remember our biology lessons and picture those adipocytes and think about the breakdown of fats via certain enzyme catalysts via hydrolysis into 3 stages, which is nicely demonstrated in the graphic that you can see on the screen now. So, stage 1 you'll see is where triacylglycerol is hydrolyzed into diacylglycerol via the enzyme adipose triglyceride lipase, or ATGL. Stage 2 then sees diacylglycerol hydrolyzed into monoacylglycerol by the enzyme hormone-sensitive lipase. Spoiler alert, this one is really important. Then finally, monoacylglycerol is hydrolyzed into glycerol via the enzyme monoacylglycerol lipase. As I said just a moment ago, the key enzyme to focus on in relation to lipid modulation and TRT is hormone-sensitive lipase. So HSL directly impacts on catecholamine, which is adrenaline and noradrenaline primarily, activity at an adipocyte level, which is a key component to lipolysis when considering CAMP, or cyclic adenosine monophosphate, which is a second messenger system used for intracellular or signal induction. It is synthesized from adenosine triphosphate by enzymes, or G proteins, that are attached to metabotropic receptors and become released when the receptor is activated. Where testosterone and DHEA come into play is at the level of that receptor, specifically lipolytic beta-adrenergic receptors. Testosterone increases the number of these receptors, so logically those with low testosterone have comparatively less of them compared to those with healthy male androgen levels. DHEA moderates lipid mobilization via stimulation of resting metabolic rate and increasing lipid oxidation, and enhances glucose disposal via GLUT1 and GLUT4, and these are glucose transporters responsible for the uptake of glucose into adipocytes and myocytes, also known as muscle cells. This is why fasted cardio for those on TRT is actually very effective. So when we think about guys with low testosterone, they struggle with weight loss because they have both low T and DHEA, and when they commence TRT, they tend to see results in terms of weight loss because of the improved lipid metabolism through the mechanisms described above. Also, testosterone has been shown to increase the expression of GLUT4 in skeletal muscle cells, hepatocytes, and adipocytes, as well as augmenting membrane translocation via that CAMP system, and therefore promoting glucose uptake in adipose and skeletal muscle tissue. This translates for patients, when combined with healthy diet and increased physical activity, in particular fasted cardio and resistance training, in an increased propensity for fat mobilization, aka fat loss, and an increased propensity for potential of building lean muscle tissue when stable on their TRT treatment. Wow, that was pretty heavy, wasn't it? Let's leave it there. If you enjoyed the video, please hit like and subscribe, and make sure you hit that bell notification so that you don't miss any of our uploads. See you in the next one.